Hello everybody. Today we are going to discuss about care bundles in ICU. So about first we will discuss about the WAP bundles. These are the essential practice guidelines from the SHIA guideline. So first one is how to avoid intubation if possible. Use non-invasive positive pressure ventilation for selected population. Then assess readiness to extubate daily in patient without contraindication. Take steps to minimize the unplanned extubation or reintubation. Avoid fluid overload. Provide regular oral care, that is toothbrushing or gauze if no teeth. Elevate the head of the bed unless medically contraindicated. Change the ventilatory circuit only if the visible is soiled or malfunctioning. Prevent condensate from reaching the patient. Use cuff endotracheal tube. Maintain cuff pressure and volume at minimal occlusive setting. Suction oral secretion before each position change. Then additional approaches are interrupt sedation daily, utilize endotracheal tube with subglottic secretion drainage port for older pediatric patient, except to require for more than 48 to 72 hours of mechanical ventilation, and go for the early tracheostomy. Then summary for the recommendation to prevent CLAPSI is that is before insertion, provide easy access to provide easy access to evidence-based list of indication for CVC use to minimize unnecessarily CVC placement. Require education and and competency assessment of healthcare provider involved in insertion care and maintenance of CVC about CLAPSI prevention. Then beg patient age more than 2 months with chlorhexidine preparation on daily basis. Then at insertion in ICU and non-ICU setting, facility should provide process in place such as checklist to ensure adherence to infection prevention practice at the time of CVC insertion. Perform hand hygiene prior to the catheter insertion or manipulation. The subclavian site is preferred to reduce the infection complication when catheter is placed in ICU setting. Use all-inclusive catheter cart or kit. Use ultrasound guidance for catheter insertion. Use maximum sterile barrier precaution during CVC insertion. Use alcohol chlorhexidine antiseptic for skin preparation. Then after insertion, ensure appropriate nurse to patient ratio and limit the use of the float nurses in ICU. Use chlorhexidine containing dressing for CVC in patient over 2 months of age. For non-tunnel CVC in adult and children, change the transparent dressing and perform site care with chlorhexidine-based antiseptic at least every 7 days or intermediate if dressing is soiled, loose, or damp. Change the gauze dressing every 2 days or earlier if the dressing is soiled, loose, or damp. Disinfect catheter hubs, needleless connector, and injection port before assessing the catheter. Remove non-essential catheter. Routine replacement of administration set not used for blood product, lipid formulation can be performed at interval up to 7 days. Perform surveillance for CLAPSI in ICU and non-ICU setting. Then additional approaches include use antiseptic and antimicrobial imperated CVC, use antimicrobial lag therapy for long-term CVC, use recombinant tissue plasminogen activator factor once weekly after hemodialysis in patient undergoing hemodialysis through CVC, utilize infusion and vascular access team for reducing CLAPSI rate, use antimicrobial ointment for hemodialysis catheter insertion site, use antiseptic containing hub or connector, cap or port protector to cover connector. Approaches that should not be considered as a routine part for CLAPSI prevention. Do not use antimicrobial prophylaxis for short-term or tunnel catheter insertion or wide catheter in situ. Do not routinely replace CVC or arterial catheter. Then unresolved issues, routine use of needleless connector as CLAPSI prevention strategy before assessment of risk, benefit, and education regarding proper use. Surveillance of other type of the catheter. Standard or non-antimicrobial transparent dressing and CLAPSI risk. The impact of using chlorhexidine-based product on the bacterial resistance to chlorhexidine. Sutureless securement. Then impact of silver xyloid imperated umbilical catheter in preterm infant. Necessity of mechanical disinfection of catheter hub, needleless connector, and injection port before accessing the catheter when antiseptic containing caps are being used. Surgical site infection prevention bundle. Wash hand with soap and antiseptic bundle on night before surgery. Surgical prophylaxis in the form of parenteral antibiotic prophylaxis. Use of alcohol-based disinfectant for skin preparation in operating room. Hair removal use clipper cream, not shaving. Then glycemic control, periop normothermia, administered increased fraction of inspired O2 during surgery and after extubation in the immediate post-op period in patient with normal pulmonary function. Bundle for the prevention of catheter-associated urinary tract infection. COUT is defined as urinary tract infection in a patient with current urinary tract catheterization and who has been catheterized in past 48 hours. Avoiding the use of urinary catheter by considering alternative method of urine collection. Methods include condom catheter, intermittent catheterization, and use of napkins. Use an antiseptic technique for insertion and proper maintenance after insertion. Following evidence-based guideline and implementing catheter insertion policies at institution. Daily assessment of the presence and needs for indwelling urine catheter. Indication for urinary catheterization include urinary retention, need to close monitor urine output in unstable patient and to assist perineal wound care. Thank you guys.